I'll focus on pericardium. What I have here for you is to present diseases of myocardial wrapping, which can come from multiple etiologies. You can get it from multiple sites of your tertiary hospital. You get it actually from infection. You get it from the oncology department. There's a large pericardial effusion in oncology patient. You can get it as part of uremia, as a metabolic cause. You get it as a trauma, or you get it after some iatrogenic accident during advancing a dilatator somewhere into the heart structures. The clinical syndromes, on the other hand, are rather uniform. You get accumulation of fluid, loss of pericardial reserve volume, and you get a tamponade, or you get pericarditis with possible constriction. The presentation of pericardial disease somehow fits into the concept of a diastolic heart failure. So you have a patient who is very sick, who is not doing well, and the patient has somehow reasonable looking ventricle with the acceptable ejection fraction, which operates at higher filling pressure states. And what we focus on will be the problem with the pericardial constraint within actually a confinement of pericardium, and it will be due to some problem with the pericardium itself or with the accumulation of effusion here. So normally, pericardium contains up to 50 mils of volume, and there's some very small pericardial reserve volume. If you have growing of the pericardial fluid, you get actually the typical loss of compliance curve, that with the accumulation of volume, you get a rising pressure. And if it's slower, as in case of oncology or uremia, you get a slower adaptation to a high amount of fluid. So you would be surprised how much you can squeeze into pericardium in some oncology tamponade, where you would drain, for example, 800 mils, 1 liter from pericardium. Or you would get a patient with trauma who tamponade after accumulating some 200, 300 mils in pericardium. So it will be much faster. The diagnosis of pericardial fluid is rather simple. It's a separation of pericardial layers, like shown here, just along the free wall of the right ventricle and beyond the left ventricle. So it's a circular fluid, and we can look at the size, actually the distance of the layers of actually the separation in the pericardium, and we would consider effusions less than 5 millimeters small. Usually, if it comes up to 1 centimeter, it's usually circumferential and it's more significant. Pericardium actually has its spaces, and if you accumulate fluid in pericardium, it usually starts to settle under the inferior wall, and then it moves towards apex and anterior wall and along the right ventricle. And if it's later along the lateral or posterolateral LV wall, then it's always circumferential and significant in terms of volume. You have to differentiate pleural from pericardial, and of course pericardial fat is more echogenic, and it's usually anterior or along the right ventricle, and it moves in concert with heart during the systole and diastole. So how to differentiate pericardial and pleural? One of the easiest rules is to look at the aorta, the descending aorta, in the groove in between of the posterolateral wall and the left atrium, and this is pericardial fluid, and when it extends beyond aorta, it's always pleural. It could be pericardial and pleural effusion. Tamponade and accumulation of fluid associates with the elevation of an equilibration, particularly I would like to emphasize the equilibration of filling pressures. There's an inspiratory decrease of arterial systolic pressure, which is and has been named in the textbooks since 19th century as pulsus paradoxus, and it's diminished in hypotension when it disappears during tachycardia. So during inspiration, you have a dip in pulse wave Doppler in left ventricular outflow tract. And this I will explain later in the pathophysiology of it. the factors related to it and to severity of tamponade is the speed of accumulation, which I've already touched during the explanation of loss of pericardial reserve volume. Then preload reductions, that is, if you have patient, for example, with uremia with pericardial fluid, and he gets a vigorous ultrafiltration somewhere in the chronic dialysis session, then he may start to tamponade, because with reduction of preload, it can actually manifest the pericardial pressure and the fluid accumulation in pericardium. The same would happen if he starts to bleed, as a bleeding would be a trigger, or if he loses filling due to some distribution cause like sepsis. And of course, if you have severe LV dysfunction and moderate to severe dysfunction, that would tamponade easier than normal LV function. There's a role of CVP if you do your rounds in the morning and you see a patient like this on the first slide with this heart-lung interaction here and with the CVP of 16. I would certainly like to look at the neck veins, and I would take actually other measures, and I would grab the ultrasound and check if he has tamponade or not, or if there's something wrong, compared to this one who has a heart-lung interaction with a CVP of 3, and this is actually a case of a bleeding somewhere into the GI tract. So CVP has a sense during the rounds. When you look at the echo, if you don't see any chamber collapse, there's a good negative prediction that the patient has not a tamponade. The lowest pressure is in right atrium and in atrial structures, so they are very sensitive to collapse, particularly in systole. But the most sensitive would be the buckling and the early diastolic collapse of the right ventricle. And as the patient inspires, or it triggers inspiration on a ventilator, it increases the flows through the right heart and reduces actually the flows that go from pulmonary veins into the left heart. And this is the essence of the pulsus paradoxus. So this is just an exaggeration of a normal heart-lung interaction. So with every inspiration, you accumulate fluid into the pulmonary artery vascular bed, and there's a less fluid for left heart. So with inspiration, you have the dip in systemic blood pressure by more than 10%. Of course, you can compress the left atrium, particularly in some atypical tamponade in left and right atrium during a tamponade related to some cardiosurgical procedure. And as part of the tamponade presentation, there should be a distension of the venous system. Very easy to assess, to see a distended lower vena cava through the subcostal window. So I give you an example. Here you see the buckling. That's the most specific probably sign of tamponade, a collapsing diastolic, mid-diastolic collapse of the free wall of the right ventricle, swinging heart in a large effusion, which is circumferential, and the distended lower vena cava. This is a hemopericardium post-esophageal resection where I drained 450 mL from pericardium, and you see it's circumferential. This is from subcostal window. So this is very easy to make, this diagnosis in the clinical context. Once again, you see the dancing heart with the rotating axis. You would probably see a pulsus alternans on the ECG trace. This is another tamponade with the type A dissection. You can see a circumferential compressing the heart, and you see hematoma here with the fluidic blood around. This is a complication of the type A aortic dissection with hemopericardium. There's a compression of the atria, and of course, complete compression of the right ventricle, which is here, completely obliterated. This is subcostal window. This is a bit atypical. You see there's a buckling and a massive collapse of the right ventricular flea wall, and this is circumferential fluid. However, if you look at the atria, they are not collapsed. So this is a ventricular tamponade in a patient after cardiac surgery. Now, if you look at this, This is mid-esophageal four-chamber view. This is left ventricle, right ventricle, and the atrioventricular valves. And there's something protruding into the left atrium, and now it's jammed. So it's a patient who has got a dip in inspiration, an interaction in the sense of pulsus paradoxus, and is not doing well. And after removal of this from the pericardium, you see that there's a normal left atrium in the same plane. This is some 40 minutes later. And this was the hematoma which was here compressing the left atrium. So atrial tamponade is something which you can see not as rare not as rarely in cardiac surgery, in cardiothoracic anesthesia, cardiothoracic intensive care. And you must be aware that you need a standby transesophageal echo to exclude this in a patient who has got normal ventricular performance but can have a tamponade due to the selective compression of the atria. So once again, a pathophysiology principle of pulsus paradoxus is somehow influenced by ventilatory cycle and interaction of the circulation and ventilation. So with every inspiration, you get an increased flow through the right heart and movement of the interventricular septum towards left, if it's really vigorous, and particularly in constrictive pericarditis. And with every expiration, you get an increased flow through the left heart and reduced flows through the right heart. The transmitral flow variation is seen here, so it should be at least, it should be varying by some 20-25% to say that this is a significant variance during inspiration and expiration. So for transmitral, this would be inspiration and that would be expiration. And this is tricuspid flow variation, where you would expect to have a higher changes in flow. So in inspiration, it would be here, and the expiration would be here, and the variation should be some 25-40%, and it would be influenced, of course, by volume loading, or it would be influenced by the mode of mechanical ventilation. So it may not be present, it's not always there. So you have a dyspneic patient on noradrenaline for hypotension, and you see has got a large pericardial effusion. But if you look at the mechanics of the right atrium, if you look at the right ventricle, and you see it here, so the question is, what's your diagnosis? What would you do? And what we did, we just keep watching him. Has got a uremic effusion, and it's circumferential, but we don't see signs of tamponade. There's not a collapse of the atrial structures, not buckling of the right ventricle. The variation of transtricuspid variation is maybe 10-15%, not more. But there's certain development, and plus 2 days, you see this. You see circumferential effusion compressing right heart. You see there's a compression of the right atrium, almost complete in systole. There's some buckling here in this segment of the right ventricle, and you see this is inspiration. So expiration, inspiration on pressure support ventilation. This is on mechanical ventilation. So this patient needs this, needs subcostal drainage. You can use a single lumen catheter, which is very cheap. You get it in, and you drain 700 mL of uremic pericardium fluid. So this is tamponade. Sometimes the differential diagnosis is not as easy. Unfortunately, this loop jammed. It's a patient after aortic bioprosthesis who presented in the obstructive shock in the middle of the night, and you see has got the compression of the right atrium, and there's a fluid along the lateral and apex of the left ventricle. And what we did, we drained some 50 mL from the apex, because the guy who was there didn't mention that, actually, and this is after the drainage of 50 mL through the apical window, and the problem was somewhere else. He had almost 1 liter in the left pleural and half a liter in right pleural space. So there's an important concept to understand that heart is within the pericardium, pericardium is in the mediastinum, mediastinum is in the chest. So if you have a huge amount of pleural fluid, you can get a tamponade as a chest tamponade, which would manifest on your echo like a pericardial tamponade. but you have to go for the highest amount of fluid, and that was in the pleura. Again, chest ultrasound is an integral part, or at least the basic of chest ultrasound, of your echocardiography. So you see here quite a nice sponge phenomena in a patient with a massive hemothorax, right-sided hemothorax. The lung is squashed here, just next to the mediastinum, and this is a large hemothorax. And the patient has got quite an extensive stroke volume variation and the distended veins. And the patient was presented with the obstructive shock due to large hemothorax. So this is a tamponade due to blood. If you look at this, this is a 60-kilo lady with a lymphoma admitted for dyspnea and in a cardiorespiratory failure. If you look at this, there's a buckling of the free wall, compression of the atria, quite an extensive amount of fluid and pericardium. It looks like, actually. But there's more than 1 liter in pleura and a distended veins. And this is just, I think it's about, it's 40 minutes later, half an hour later, after we drained bilaterally quite an extensive amount of fluid. And this is the same pericardium without actually getting a needle into the pericardium. So we drained just the chest, and this is the same plane after having removed almost 2 liters from pleura. So this is chest and heart tamponade due to the amount of fluid in the chest. This is a very special case, a guy who was dyspneic for 3 months, and then he collapsed after lifting some bricks in his work, and he collapsed and was brought in, retaining saturations on 100% oxygen. And what we did first, we saw actually these compressed atria and the amount actually of fluid in the pericardium and the distended veins. So he got a catheter into the pericardium immediately, because always we go first after the heart and the big vessels. And so immediately after the admission, he got drained some 100 mL from pericardium. And then we realized that the reason why we didn't see sliding at the beginning was that we missed the bilateral pneumothorax. And this is, and he absolutely improved after getting 2 drains in. So he presented with the chest and heart tamponade due to air in both pleural spaces. And this was a chronic pneumothorax with a new pneumothorax on the other side 3 months later. A mediastinal tamponade, there's a hematoma just above the pericardium, can sometimes be very tricky, because if you imagine that you get a bleeding from the aortic arch and it can press down into the bifurcation of pulmonary artery, it can cause enlargement of the right heart, and patient can even show some pulmonary hypertension. At the same time, he may bleed, and so it's quite a tricky diagnosis. This is a patient after tricuspid annuloplasty, and this loop, unfortunately, is jammed again, and I wanted to demonstrate a paradoxic subtle motion. This is a short axis of this heart. So this gentleman had drainage of this, which is a collection above pericardium and mediastinum, through the parasternal approach. And I would like to recall the proceedings in hypotension and the shock states. So once you secure actually the airway and you secure the vein axis, then the first step is to exclude a presumed obstruction. This is the first here. And then you go after actually excluding the pump failure and indication to cath lab and other things, and then you get to hypovolemia and distribution type of shock. So the first line treatment is to use unavailable imaging and exclude obstruction. So because the primary therapy of obstructive shock is drainage, which you should be able to do fast and immediately. And the drainage is emergency. You get it either as a diagnostic for purulent or to exclude hemopericardium. You always like to remove blood from pericardium because it may cause fibrosis and constriction later, as well as the inflammation. So you would probably use the subcostal, apical, or eventually parasternal. This is before the drainage, sorry. that was before the drainage, a circumferential fluid, and this is after the drainage in parasternal long axis. You can use single lumen or you can use pigtail. This drained very well. Is a patient brought in from the cath lab with hypotension and with the draining pigtail. And you see the reason why it was draining so well, because you see a 4 millimeter structure in the middle of the right ventricle. And this is a pigtail. So I was keeping the TOE probe in for a long time just to see. Now the moment when I pulled the pigtail out, it disappeared. And just to add and note that even the 4 millimeter hole into the right ventricle can sometimes close itself, and you wouldn't go for cardiosurgical theater after removing this misplaced catheter. Constrictive pericarditis is a filling disorder due to rigid heart confinement. You often see a normal ejection fraction, normal size ventricles. You see multidilated atria. There are a couple of etiologies, as I showed you at the beginning of the presentation. What's typical is actually the enhancement of the pericardium. And you see the moving septum, the septal bounce, which is just an exaggeration of the heart-lung interaction typical for pericardial disease. So from this loop, you could see that, for example, now is coming the inspiration. It moves towards left, and now it moves to, now it's left, and now it moves towards right. So that will be the inspiration, and that will be the expiration. And this septal bounce is something typical for constrictive pericarditis. You see most often normal ventricular relaxation. You see sometimes asymmetry of the tissue Doppler, particularly between the lateral and medial mitral annulus. And in contrast to tamponade, the atrial filling can be preserved in diastole because the heart normally relaxes, but it's the time of relaxation and the filling is short due to the rigid confinement due to constrictive pericarditis. This is slightly different from tamponade. But there's, again, the ventricular interaction, which is exaggerated, and the septal bounce can be seen on the mode here as this notch, which protrudes more and more here with the inspiration on the septum towards left ventricle, and then it becomes less again with the expiration, so the inspiration, expiration. So this actually differential diagnosis between constriction and restriction is somehow outdated. If you think about the normal filling pattern of the left ventricle in constrictive pericarditis and the interaction between inspirium and expirium, in contrast to restriction, because the restrictive pattern is something which associates with high filling pressure, so you get a spiking E wave and very short deceleration time. So it's very different to constriction in nature and in pathophysiology. This looks very complicated, but what I want to stress is you've learned a lot about the SVV, the stroke volume variation, and how you can use it for a diagnosis of hypovolemia. But just to be sure that you can load a patient with fluid, you should be aware at least about some rough LV status, RV status for delta up, delta down. And pericardium is an important variable because if you have a pericardial tamponade, you get SVV. And this would be a false indicator to substitute fluid. Instead, you should go for drainage. And of course, you should know how you set the ventilator, and you should probably consider maybe some dynamic changes if you like. So my conclusion would be that tamponade and pericardial pathology is a clinical diagnosis, not purely echocardiographic. You can make the diagnosis at the first instance through simple measures like compression of atria and ventricles, and look at the venous collapsibility. You add your Doppler variation, particularly mitral and tricuspid flows. You have to think as an intensivist about also a potential of mediastinal and chest tamponade. And you should know as an intensivist that cardiology wouldn't do more pericardial drainages as compared to intensive care. And you could do it yourself if you know echocardiography, because the drainage under the echo is generally safe. And I thank you for your attention.